thank you all for joining us at the Alaska Eating Disorders Fall 2024 ECHO. I am one of the co-founders of Alaska Eating Disorders Alliance and also the board treasurer this year. Today's ECHO session and all of our ECHO sessions offer a forum for Alaskan interdisciplinary healthcare professionals to connect with eating disorder experts and with each other. So we will have 3 more sessions after today in October. They will be the next 3 Thursdays from noon to 1. So, and stay tuned for 2 more sessions in early 2025. I want to thank ConocoPhillips for their support of this educational session in this series. Each session will include a didactic presentation on a key eating disorder topic from a subject matter expert. There'll be a time for your Q&A and a case presentation from a local provider with opportunity for you to engage and learn from other professionals in your field. The series has been guided by a hub team of professionals and experts in eating disorders, including Dr. Yolanda Evans, with therapist Katie Bell, dietitian Jessica Setnick. I believe they've introduced themselves in the chat. You can find their bios, or we'll be able to find them shortly in the chat. And our session has been approved for CEUs, and you can claim 1 credit hour per session of this ECHO series. In order to claim the CEU, you must attend the live session. So if you're seeing this afterwards, you won't be able to get the CEU, but it's still worth watching. You must attend at least 90% of the full session time and complete an evaluation form, after which you'll be redirected to receive and download confirmation of your CEU. At the end of our session today, a link to that evaluation will be put in the chat box. And thank you in advance for filling out the survey, because it tells us how we're doing and what we can improve. So before we jump in, a few Zoom reminders. The closed captions are automatically generated and available by pressing the CC button at the bottom of your Zoom screen. Please take a moment to turn on your camera so that we can get to know each other. Please keep your mic muted during our presentations and when you're not speaking. Engagement with this group is integral to the All Teach, All Learn philosophy, and that underpins the ECHO program. We encourage people to ask questions and make comments during the session by using the chat box. And when Q&A opens, you can unmute yourself and share directly with the group. You can also private chat the session host, Kaylin Hooley, myself, or any member of the hub team if you like your questions shared anonymously. I want to mention that if you've been to our ECHOs before, this is 1 hour instead of 1.5 hours, so it'll feel a little bit faster. We'll be paying a little bit more close attention to the time. If you're joining us now, please do introduce yourself in the chat box. Share your name, your role, your organization, where you're joining us from, and if you want, what you hope to get out of this ECHO. And hub team members have introduced themselves as the hub team participants as well. Please note that the opinions of the hub team and the presenters are their own and do not necessarily represent those of AKEDA or any ECHO sponsor. Additionally, Project ECHO is not HIPAA compliant. Therefore, no protected health information is to be shared or displayed at any time. Thank you to everyone for following these guidelines. And finally, I want to pause for a brief moment for our land acknowledgement. And while this is a virtual presentation, and folks are joining us from many places from around the state, maybe outside of Alaska today, the AKEDA team is based in Anchorage on the unceded lands of the Tanana people who have lived on these unceded lands for thousands of years. We want to thank the Tanana people for their stewardship of the lands, water, air, and all life that sustain us. We also recognize that today is the Alaska Federation of Natives Convention. We apologize for any inconvenience that holding this session today might have caused. Now I'll share about the vision that's driving this initiative and offer some reminders about best practices and listening in today's session. The goal of Project ECHO of our Project ECHO is to work together to grow capacity within our local healthcare system to better understand, diagnose, and treat eating disorders in Alaska. During our time together, we'll be learning through the presentations and discussions and want to be mindful of creating a welcoming learning community. Words matter, they're powerful. This is an open space where all voices and all bodies are welcome. We encourage you to seek ways to use inclusive, non-stigmatizing language. And here's today's agenda. We're going to start with a presentation by Dr. Margaret Carlson Cosentino. And Dr. Carlson is a family practice doctor with Southcentral Foundation. She has lived and practiced in the state of Alaska since 2015, after graduating from Midwestern University with her Doctor of Osteopathic Medicine, or DO degree, in 2012. She's a board-certified family physician who has worked with the Alaska Native Tribal Health System since 2015, first with Tanana Chiefs Conference in Fairbanks, and since 2018 with Southcentral Foundation in Anchorage. Dr. Carlson has a long history of involvement with eating disorders associations. She participated in eating disorder support and awareness groups while in college, as well as during her years in medical school. After the presentation, Dr. Carlson will answer some of the questions that you might have. And then our session will conclude with a case presentation by Irene Saxton, who's an LMSW. And now, without further ado, I'd like to pass the session over to Dr. Margaret Carlson Cosentino to share her didactic presentation.
Thanks, Beth. Appreciate it. Okay. Welcome, everybody. My name is Meg Carlson. As I was introduced already, I'm going to quickly share over to my screen. So bear with me as we move over to this. And get this up and running. Okay. So I also, that wasn't in my bio, that I do and why I was asked to kind of be the one to present on some of this is because I also am certified in obesity medicine and board certified in that for the last 8 years. So I have interestingly worked in 2 different spaces in the spectrum of people that have been, that seek concerns for issues with weight. And I will say that obesity, I know, is a really biased term and nobody really loves it right now. But unfortunately, in medicine, we are still calling it that. So during this presentation, I will be referring to that just because our societies are still labeled that. There has been talk of changing that, but just to kind of know. So really navigating GLP medications is the kind of focus of the talk today. I kind of call that treating disease without creating disorder. And then really it's just been a thing that we've seen. I think everyone knows now about GLP medications. The explosion in the media has really kind of put those out there. So really what I wanted to do today is quickly break down an understanding really of what are these drugs that patients are coming in to ask for or who might be taking that are seeing in practice, but also really be able to identify some tools when we're dealing with patients coming in on these medications or asking for them so we can better evaluate for disordered eating patterns in our patients coming in on these or taking these. I have no disclosures. I am a member of the AKEDA board, so that is something that is out there, but there is no financial gain that I have from any of these medications I'll be discussing today. I'm going to jump into a case presentation because I think as a physician, that's how I best learn. So I'm going to bring up a case that has been one that I've recently seen in clinic, but I have many similar cases like this. So this is a 45-year-old female coming in to see me today for a history of hyperlipidemia. I haven't seen her for 6 months, and she said, well, I'm really watching my cholesterol. I've been intermittently fasting because I've read about that, and I'm tracking my calories. I'm following this keto-based diet because I heard that was good too. But I really have read and heard friends that are taking these medications, and I want to know more, and I really want to go on them. And specifically, she asked about Wegovy or Zepbound. She's from your EHR, you pull up on your screen. She has had a BMI, which is what your EHR calculates. It was at 35 when you saw her last, and now it's 30 6 months later. And most notably, her heart rate is also lower, or bradycardic, we call that, under 60. Notably never had that low of a heart rate before, and her blood pressures have always been in the 120s, but now they are much lower at 105/68. She further kind of talks about how bad carbohydrates are and how she's only doing plant-based eating. She's saying that she's cooking for her family separately because they don't like to eat how she likes to eat. And she is really struggling with cravings, which is why she wants to know about these medications because she's getting frustrated by that. She says she's burning off calories by going to the gym or running outside when she can. And she's tracking herself around 1,200 calories a day that she's decided to set with no guidance from any dietitian in my clinic or myself. So a big thing is where I kind of like, how do we respond next? And I think there's just a lot of things you want to be cautious about when you're seeing people in your clinic that are starting to have these concerning things or talking excessively about some of these issues about their weight, where you want to just be cautious. I look at that as some red flags when I first start to see somebody that comes to see me. So if I look through my chart, I see that there's calculate 40% weight loss that she's had in 6 months since she saw me. So that's 16% weight loss from where she was at, which is a lot. And she's still distressed by this, by her weight, despite some loss, and as well as her heart rate and blood pressure are also much lower than normal, which worries and cues me in on that. Maybe there's like some serious restriction that's happening to make her heart rate and blood pressure change that much. This fixation on like avoiding certain foods, I'm always kind of red flagged when I start to hear that, as well as that she is not eating with family, has started to eat on her own. She's restricting heavily throughout the day. And then she is also treating exercise as punishment, as burning off, or terms that she starts to use in a way that's like a punishing way of moving our body. All those things make me want to take pause and really think very well about how I'm going to respond to some of to her questions. I also kind of know that when patients are coming in, they've seen a lot of ads that we're seeing. These are just a few, and I'm sorry for some of them being slightly triggering and things that I would never want to put up, but just putting it out there for us that are providers, so we kind of have an idea of what are our patients being exposed to, what is out there, what are they able to see. I will say all these are mostly not put out by the companies that make these drugs, but there are so many other places that you can go online to get similar drugs or compounded drugs that you can go and you can get a doctor appointment by clicking that tab, that you don't have to see a person, that they can just mail you medications. And so this is what everyone's being exposed to right now, right? These quick things, these being told that, you can modify your meals because you're on these medications. And so just a lot of very harmful talk that we've seen kind of explode over the last few years with a few of these medications, and specifically the GLP medications. Oops, I am sorry. Okay. So that kind of brings me to how do we respond? Screening for disordered eating. I think in anybody that's going to be prescribing these medications, in practice, you should be very well versed on how can we screen out when we're starting to hear those red flags. And even if we're not good at picking up those red flags, what can we use? What tools can we have so that we can feel more confident to be sure that we're not prescribing medications and just helping people continue along a disordered eating path and worsen their disorder. So just because we're kicking off this session, I was just going to do a really quick just reminder for people just about what are those DSM criteria for eating disorders. So you can kind of refresh your memory if you haven't been to one of our sessions before. That's where, anorexia, I think, is one of the things that is the one that most people kind of know about. But just as a reminder, that's really that restriction of energy intake is the hallmark of this condition, right? That fear is what we really kind of pick up on a lot with those patients. There's that fear of weight, of gaining any weight, and that also distortion of view of one body's weight, or what we look like or the shape that we're in. There's that overvalue of that, and that discrepancy where they don't see or deny, despite at a serious amount of weight loss, they still don't see that. I think the biggest one that I will highlight down here, because I see more commonly in my practice specifically, is atypical anorexia, these are those people that are not at a BMI that is underweight, but that they have lost significant amount of weight and are continuing to lose weight and are significantly distressed by that. So they're meeting all the criteria, but they are just not at a lower BMI. So I will just highlight for you, especially in the realm of when we're talking about these medications and patients coming in on these, really reminding you about thinking about atypical anorexia. The next one is bulimia nervosa. I think also a lot of people kind of have an idea of this one. That's where eat in a small amount of time, a large amount of food, feel very out of control with eating is the kind of hallmark of that one. And then we'll engage in some behavior, kind of compensatory behavior, whether that be, I think everyone thinks of purging is, that kind of vomiting afterwards, but also reminding you that that can just also be excessive exercising, right? So also kind of thinking about asking our patients that are coming to us about this, about after you eat or fullness, are there other things that they are using? And that can just also be excessively exercising to burn off those calories. This is for the DSM criteria, at least, has to be ongoing for a period of a 3-month time. But I will tell everybody that just if you don't meet the criteria, that doesn't mean you don't have a disorder. So reminding that even if they meet some of these and not all, the time frame especially, I still would be worried and considering an eating disorder. The last one that I also have seen, this is the largest group, and I think really when I started almost 8 years ago working in the obesity medicine space, I really started to diagnose this more commonly. And it's not surprising because this is the most common eating disorder that we will see. And so this is where your patients will come and say they are eating in a large amount, binging. They feel distressed by this. They feel like they have no control. And then they don't do any compensatory behavior. So it's very similar to, the bulimia kind of discrete time, but there is no compensating behavior after. But there's just marked distress by these episodes. These episodes make people feel bad. They feel guilt and shame. And then that is just like hangs on to them. And this is where this period of repetition that occurs with that too. I also would remind you that some patients aren't always meeting these criteria, but I still would be very careful. Had other people say that, well, if they didn't do it enough, then they weren't having binge eating disorder. You're feeling this bad and eating in a small period of time like this, and this is causing distress, I'd say always thinking about disordered eating. We always can label it eating disorder, not otherwise specified. So reminding everybody that if there even are some of these criteria, I would be very cautious and really trying to go down the treating and learning more for your patient. So what can we use? What screening tools can we use for these disorders? So the SCOFF is one, and these are ones that you can feel like, I'm going to bring up a couple of them, but I just would tell you to use whatever one you feel comfortable with and get good at it so that you can start to practice that daily when you're starting to see patients. But the SCOFF this S is for, do you make yourself sick because you feel uncomfortably full? Do you worry that you've lost control of how much you eat? And then have you recently lost more than 1 stone, which is 14 pounds in a 3-month period? Do you believe yourself fat when others feel like you are thin? Or would you say food dominates your life? And you get 1 point for a yes. 2 or more is a higher likelihood that your patient has an eating disorder. The other one that we have is the ESP, or the eating disorders for primary care. This is also a little different, but very kind of similar things that we're looking for. Are you satisfied with your eating patterns? That can be, is it yes or no? Then it's, abnormal would be if you were saying you're if you're unsatisfied, sorry. Do you eat in secret? Also concerning. Does your weight affect the way you feel about yourself? Have any of your family members suffered with an eating disorder? And then have you currently suffer, or do you have suffered with an eating disorder in the past? And then 2 or more abnormal responses is a higher likelihood. I feel like this one I personally find helpful because I work in a primary care space, and family history is like a routine thing we discuss. And so if you are, those are sometimes, this one can be a helpful one to kind of start asking that way, and then getting more into like, how do you feel about your eating? So for some people, that might be a better one. This is also, I don't routinely use this, but this binge eating screening disorder is also available that you could have patients fill out if you have an electronic way. It's kind of a click one that you could do or hand out before. But this is also looking more about binge eating screening specifically. So back to kind of going back to our presentation, does our patient that we're talking about have a eating disorder? Well, so I asked her a little bit more about the questions. You know, with all these changes you've had and you've made in your diet, I wonder, how are you feeling like actually with all these changes? And she says, oh, I feel awful. I need to lose more weight. I'm not satisfied with my eating patterns. And I said, do you feel like food is starting to dominate your life? Do you feel like you're thinking about this all the time about food? And she breaks down and starts to tear up and say, yeah, I think about actually food all the time. And how many calories I'm consuming. And then does that make you feel like hopeless? Are you feeling hopeless? Is this, thoughts of this starting to really make you feel sad, depressed, or hopeless? And she says, yes. So that she definitely screens a SCOFF score of 3 as a positive screener. And at this time, I'm definitely not going to want to talk about Wegovy or Zepbound and really switching to engaging her, bringing up concerns that I think there might be an underlying disordered eating pattern she's developing. And this is distressing. And how can we partner with her and really bring a team approach to her to help overcome these? These are difficult conversations in anybody that's practicing in primary care or who is being asked to prescribe these medications. It is always harder to have to sometimes have these conversations, but I would encourage you to definitely have space, have the time, bring up the concerns. It's easier to write a script, but at that point I would stop and really reevaluate where you're at and really try to engage and create some relationship with that patient so that we can help her move forward and not go down the path of just seeking to get a medication that's going to push her further into her disordered pattern of eating. So I'm going to kind of then just quickly as a highlight, because of how did we get here? Why are people asking for these medications? What is all this? If you are, unfamiliar or just starting to work in this space, I think it's kind of important to know why are these here. So where did this all come from, as well as the pathophysiology behind these drugs. So this is a very busy slide. It really just is trying to show you there are a lot of different hormones that affect our body and really help us. And these are have great reasons, right? Our body creates these hormones, right, to really help us regulate our energy expenditure and our appetite. These are things that have been created so we could live in times of famine and be able to regulate our body function. So many of these things are active in our system, and is why weight and weight gain and loss is such a complex process. So why I think it's helpful to also know this when you're practicing in the space is to sometimes I let my patients know about the complexity behind their body and all these hormones that are there, not to harm them, but to help too, and this delicate balance. And so if we throw these balances off, we can really see a lot of changes in the negative to our body. And so that's where this is it's a very delicate system, as well as a system that is not just about, what you eat less. There's so much more to our weight and why we hold weight and the pathways that are involved with that. So really, I just show this for that knowledge that this is a complex system that we live in and our body is regulated in. But this is also where GLP comes from. GLP comes from our intestinal system. And as you can see, the end of where it touches a lot of organs. GLP medications were first created for our diabetic patients, which is why that's, the pancreas is hit and it increases our insulin sensitivity. So that's why our diabetic patients were first started on these medications. But it also why it's really been used more in the weight realm is this kind of appetite in the brain and like a certain pathway that it can hit. And doesn't hit all the time, but it can. But it also affects the stomach functioning. So the stomach also will slow, it'll decrease gastric emptying, and it also has some cardiac hits, which are actually separately being used with this medication for patients with cardiac dysfunction heart failure because of some of these things. So it's a very complex hormone that we see that does touch a lot of different areas of the body. And that's like where it was designed to come, but that's how it kind of came out. The obesity algorithm, why I bring this up, is for the obesity societies. Back about 10 years ago, this endocrine society, the American College of Endocrinology, really came up with looking at metabolic dysfunctions and specifically things that were looked at from maybe adipose tissue that had gone awry or changed some signaling. And so they created this obesity algorithm to try to kind of break down some of the diseases that they felt were related to adipose disorders and how we could target some of those. Those were the first generation of medications that were looked at. And also at that time, these medications were producing modest amounts of weight loss, 5% on average. But really it was looked at from their guidelines that you needed small amounts of weight loss to change some of these things. So the older class, and as I said, these were 10 years before some of these newer GLPs have come along. It was really looked at smaller weight changes, but longer term could help with some of these underlying metabolic dysfunctions. And really a big part of this that has been brought up many times in the obesity societies and the endocrine societies has been really trying to, obesity is not the right term. I think everyone feels like even there is, it's really looking for this adiposity or the fat that's making changes that is causing disease. So it's not just a BMI, it's much more than that. And so that I think is also important when we're reminding our patients, it's the BMI, even when we're talking about these things, it's not really the right kind of term to use. And BMI also has a lot of limitations. We have used this is really just a math equation that has been used since the 1800s, that was refined a little bit in the 70s, that really just looked at male patients that were white and never really looked at females. But unfortunately, because of just the nature of trying to find a better way to do it, that causes, the only other thing would be a DEXA scan, which is expensive, or CT scans. So it's still used because it's just a screening that's quick and inexpensive, but definitely by no means is a great idea to measure fat or adiposity, we call it. And so really it's not a great diagnosis of telling anybody that they are overweight or obese, because it's just a bell curve that looked at males. So for really kind of like thinking about that as we're going into a lot of this when patients come in, or if you are a prescriber, is really thinking about, because of that limitation with BMI, a lot of these medications are really trying to target underlying disease processes. And so the two right now that I think, just kind of highlight just for you that might be working with them more, the semaglutide or Ozempic, or now Wegovy, is one that we are commonly seeing a lot right now. And then the tirzepatide, which is the Mounjaro or Zepbound, is the other one that we see. So those are the two different ones. There are other older GLPs, but in terms of what most patients are coming in to ask for now, these are the two ones. They are very similar, except I will say tirzepatide is a newer one on the block, and they just data behind that is a little bit less than we have for the semaglutide. I think a big thing to know about when you're seeing patients with these two, especially when we're thinking about, other risks for medications or side effects and symptoms, is really just the GI risk, as I showed you that picture with all of those end organ pathways that are hitting. The GI system gets hit the most with these medications. So a common side effect on these medications is nausea, vomiting, a lot of diarrhea sometimes, constipation is really common. As you can tell, if anybody thinking about this working in a world of, patients with an eating disorder, that's going to mimic a lot of things, right? The constipation, the gastroparesis, and it's going to worsen stuff for them too, if that's very commonly. But what I do commonly see is gallbladder disease. When we have weight loss that's quick, we can develop gallstones, and that can actually more likely that I've seen trigger pancreatitis that we will see. And bowel obstructions also has been seen in the literature. I will say in practice, not as common, but also a risk for our patients. And that's where I think a lot of things, when we're talking about these medications, that people really have to understand these risks, especially if you're undergoing surgery, or anesthesiologists have been worried about food doesn't pass through as fast, so you have to keep these patients off of their GLP longer. And even then, there's even controversy if that even works. So most of them have to just be on like treated as if they have a risk for aspiration. So those are just kind of real things. I think in my practice, I see I do all ages care, but I do a lot of prenatal care and pregnancy contraception issues. So I always think about pregnancy. We are seeing a lot of women that are at the age of fertility coming in and wanting to start these medications. And I always remind them when we're going through this that we don't have data on that right now. We have limited data on what is the effect long-term for anybody that's been exposed to these medications and become pregnant. So right now, that is a big thing. ACOG has put out like 6 months before wanting to conceive, you should be off these medications. So I do always kind of put that out there and do not recommend a medication for like this, especially the GLPs with limited history in a patient that could become pregnant. And so that's just, I think, a big thing, especially in the population that we'll see that is looking to use these medications. And then a big part of this too is knowing all those hormones and those pathways. We know when we remove these medications, weight goes up. So we take away the hormone, weight will go up. And I've erroneously heard many physicians say, well, we'll try it for a while and then your body will click in and you'll continue to lose weight. That has not been studied at all. If anything, it's been disproven in all of our studies that if we remove that hormone that we were replacing, which is the GLP especially, we see that weight trajectory go up. And I think it just is damaging to patients when you are setting up that expectation of that this is not them, this just happens to every person. This isn't you trying not hard enough to keep the weight off. This is just going to happen to anybody in the study. And these studies had people following intense dietary guidance when they were being followed, and even after the medication was off. So I think also a big thing for anybody on these medications or looking to go on these medications is really that if they work, they are chronic medications. And that is a hard thing to wrap our head around when they are, as I said, it's 10 years that we've been doing this, but for long term, I think it's really having to think about and making a patient understand these are not a short term make you lose weight. These are things that are looked at as a very long term medication. And it's not you, and it's not a failure if you stop it and you gain weight. That is just what happens to everybody on these medications. So I think really coming back to is weight is so much bigger. And as I said, this obesity term I don't love, but that adiposity thing, you know, there is so much more to these, as you can tell with all these hormones. Disorder, you know, even if with metabolic underchanges, there's so many things going on. And it's also so much with we have genetic factors, environmental factors, different immune modulators that have been looked at about how our weight changes, and then behavioral different pieces. So I think a medication is just a piece. And I do think a lot of the obesity, this is from the Obesity Medicine Society, medication is just looked at as a piece of the puzzle, but it is not they call it the 4 pillars. There are 4 pillars. It is one of the pillars, but it is not seen as all. So I always kind of having that in the background of when I'm talking to people about these medications were never meant to be taken and then you just go away, even if you qualify with having a metabolic disorder or other conditions. It was meant to be team-based care, always. And so I think the hard part right now that we've been seeing with GLPs are they're being prescribed online, they're being prescribed as, you know, just take it and don't follow up with anybody. I would highly encourage anybody who is doing that to, you know, really, I kind of look at it like antibiotics or prescribing opioids, like being really cautious all the time. And then also making sure we aren't just letting patients just go with a medication script, because then you really are just sometimes fueling a disorder. So these are kind of my points on just how could you manage responsibly. I think it is possible, but I think it's always something that I always am very careful and cautious. And I have just I have a team behind me, a dietitian and a behavioral health counselor that work with me on all of these cases, because we are always screening early and often if we're treating with any of these medications. GLPs are one of them, but especially with them, And then really avoiding talk on size. Even when I'm seeing people on these medications, I'm not going to congratulate on changing your size. That's not the point of these medications, really. They're to change underlying metabolic concerns. And then I always remind them that really the working towards overall health and improving just their health and chronic disease management is really what the goals are of these therapy. It's not a number on a scale, and that's just something that I always would push away from to try to manage responsibly and avoid creating disorder. These are some of the resources that I've pulled from. These are a couple of our great eating disorder associations, as well as I said, the Obesity Medicine Association, where I got their pillars and some of their stuff. The Obesity Action Coalition is also one that supports and is trying to provide weight bias awareness. So they are also a great organization. And our local AKEDA, I'd like to just put a reminder that you can, if you haven't already gone to AKEDA's website, there is a lot of resources that we have. And we also have been very fortunate to have the ability to be starting a support group. And there also is a family and friends support group. So even if you are somewhere where it's tough to find resources, there are these other pieces, as well as we have connections to other national organizations that can give you other resources as well. So I'm sorry for this being a very quick overview, but tried to condense as much as I could in a small time. So I really appreciate your time, and thank you for the interest in just this conversation.
Thanks so much, Dr. Carlson Cosentino. This is Beth. I think we just need to do that. Okay, great. We only have a few minutes for questions, like maybe 3 or 4 minutes, but we have a lot of great questions. So I think I'm going to just share with you a couple that you may be able to answer kind of quickly, and then some others we'll have to figure out. Sometimes we're able to look at this again at the next session. So one question is, due to time restrictions, physicians have very limited time to ask questions or do screenings with patients. So how do you discuss and recommend these meds, with the providers who have patients with eating disorders?
So I will say in my practice, I have some luxury of changing, my schedule a little bit, but I always make these initial wait appointments longer. So when we get a request for a new patient that's seeking like a weight consult appointment, they are longer because I know I can't do this in a short time. And it shouldn't be done in a short time because I do think that's when you run the risk of missing something.
Great, thank you. Do you have any recommendations on working with patients who are already established on GLP-1s with an active eating disorder?
Yeah, so I think those are really tough cases. As I said, I have seen them come to me. I've had colleagues in my office with that, and I think the best way is to slowly kind of start to continue to gain trust, bring up those concerns with your patient that are on these medications, that I'm worried that this is potentially worsening your underlying disorder, and trying to, I know it's usually not going to be a great the first time, but I think if you continue to have those conversations, I've had some luck with trying to gain that relationship and improve that relationship and really kind of gain some trust so that they start to hear it, like especially talking more about how they feel and how we could help, how that feels really awful, like you're feeling horrible all the time about your weight. How can we help and change that? And that's where I've sometimes been able to convince them to check in with a counselor. Sometimes that's with me in the room to try to help gain that just for relationship building and trust towards the team. But these are difficult cases for sure.
Great. In this one, I'm not sure if you'll be able to address it, but do you have recommendations for conversations with patients under the age of 18? And how do you navigate that when caregivers are requesting medications for a child, or when a teenager requests a GLP-1, especially when there might be a disordered eating pattern?
Yeah, so I mean, I don't really go into the pediatric obesity realm just because I find it's a little controversial. And personally, I bring up, and I've had those 17-year-olds that are in my room talking about, I want to go on these meds, I want to do this. I mostly talk a lot about, as I said, that if this medication was to work, this would be your whole life on it. And what does that look like, and how, and also I don't know what that looks like for your potential risks for these medications, especially if you're female or even if you're male and looking for, having children in the future. We just don't have so many answers yet. And that's usually what I bring up, just that lack of data and lack of knowledge of that those long term, that I just don't have those studies to give. And that makes me take pause as a physician, thinking about is what is the potential for these medications to do to you in the future. So I mostly try to recommend that we, as I said, bring them together with my dietitian, and then we start to really reevaluate, like, where are we at and how can we help. And it's not about the weight, but it's about how are you feeling and how do you feel in your body. And that's then when I can kind of open up my counselor sometimes to them too. But yeah, I mostly talk about, as I said, just that whole weight one, where that we have, when you go off of them, this is forever. A lot of people, when they hear that, don't like that. And as well as those risks, especially being female. And if you have a child, I don't know if you could have a successful child or what that risk would be for your child. I just don't have the data.
Yeah, thank you, Dr. Carlson. I think that we're just going to have to wrap that up because we want to get on to our didactic presentation. But those are really great questions, and we appreciate your presentation.